Great. So I'll take a moment here to introduce Dr. Brewer. So with us today, we have Dr. Tim Brewer, who is a professor in the Division of Infectious Diseases at the David Geffen School of Medicine at UCLA, and a professor of epidemiology at the UCLA Fielding School of Public Health. He is an authority on using analytic methods to optimize the population-based control of infectious diseases. He has extensive experience developing and overseeing training, education, and service programs both locally and in countries around the world, and he has received multiple teaching awards for his efforts. Dr. Brewer served on advisory boards and review panels for numerous international and national organizations, including the World Health Organization, the NIH, the CDC, and the Canadian Institutes of Health Research. He currently serves as chair of the board of directors for the Consortium of Universities for Global Health. Dr. Brewer has presented 2 webinars for our network in the past, both on COVID-19. These webinars discuss the science behind the pandemic and strategies for controlling its spread. Today, he will expand on these webinars by discussing the emerging Delta variant. So please join me in welcoming Dr. Brewer. Thank you so much, Dr. Brewer, for being with us today.
Thank you very much, Martha, for having me, and I'll apologize in advance if you happen to hear my dog bark in the background, which occasionally happens. So today we're going to talk a little bit about COVID-19 variants and finish up with pregnancy too, and talk about COVID and pregnancy. So I do want to just remind us a little bit about COVID. So a very brief overview of some things we've talked about before. We'll talk about what actually is a variant, how do we define it, how do we categorize them? We'll talk a little bit about Delta and some of the other variants you probably heard of, Beta, Gamma, Mu, and Lambda, things like that. Then we're going to focus a fair amount on vaccines and what do we know about vaccines? How well do they work? What are breakthrough infections? Do you need a booster? And then finish up in COVID in pregnant women, and then I'm really delighted to answer any questions you may have. So where do we stand as of today? If you heard President Biden either today or yesterday talking about COVID and the plan to provide an additional 500 million doses of vaccine to other countries, he mentioned the fact that we've had over 675,000 deaths in the US. Unfortunately, right now, about 1 in every 4 deaths in the world from COVID is occurring in the United States, about 42 million cases. California, we're actually doing pretty well. We actually have the lowest 7-day case rate in the country at the moment. And our test positivity rate is running around 3%. Recently, when we peaked, we were up around 9%. LA County, very similar to what we see in California, not surprising because we account for such a big chunk of the population. Here we have about 1.4 million cases and almost 26,000 deaths. In terms of vaccinations, nationally, about 55% of the population is vaccinated. Here in California, it's almost up to 70%. LA, they only give us data for populations over the age of 12. So if you remember right now, vaccines are not available for individuals under the age of 12. And in Los Angeles, 68% of the over 12 population has been vaccinated. For the country as a whole, it's about 64%. So we're doing a little better than the country as a whole, but not a huge difference. So we're going to be spending a lot of time talking about the SARS-CoV-2 virus, or the severe acute respiratory syndrome coronavirus number 2, the original one. The original SARS virus occurred in 2002, 2003, caused about 8,000 cases globally and about 800 deaths, so a case fatality rate of about 10%. Fortunately, SARS-CoV-2 has a much lower case fatality rate. It's running about 1% globally right now. But these are RNA viruses, and that's going to be important when we talk about variants. And really, the only two we worry about are the alpha and the betas. They tend to cause respiratory tract infections in humans and gastroenteritis in animals. There are 7 human-associated coronaviruses right now, 4 that cause common colds. We tend not to think about them too much. The recent zoonotic coronaviruses, there are 3, SARS, MERS, and SARS-CoV-2. A zoonosis is just a infection or a pathogen that starts in an animal and manages to jump a species barrier and get either into another animal or eventually into a person. We think for SARS, the original host animal is a bat, somehow got into a civet cat, and from a civet cat into humans. For MERS, the Middle East Respiratory Syndrome coronavirus, again, bats are the natural reservoir. They got into dromedary camels and from camels into people. Fortunately, that particular coronavirus did not adapt well for human-to-human transmission because that has a case fatality rate of about 34%. So of the coronaviruses, that's the most pathogenic, but it's also probably the least transmissible from human to human. So we have not, fortunately, had big outbreaks of MERS. And then more recently, the SARS-CoV-2 virus, again, we think that bats are the original host. There's a couple of bat coronaviruses that are very similar, about 98% homology to the SARS-CoV-2 virus. We don't really know if there's an intermediate host or not. We haven't identified one. And importantly, the SARS-CoV-2 virus, as the original SARS virus, binds to the ACE2 receptor in human cells. Unfortunately, these receptors are found on a lot of different cell types. So you can actually get virus in respiratory epithelial cells. You can get it in myocardial cells and neurons. So that's part of why this virus causes the problems that it does. And the other big issue is this virus has now become very well adapted for human-to-human transmission, and we're still dealing with the consequences of that. So why is being an RNA virus important? Well, it's important because RNA viruses make mistakes when they replicate. So they have what we call mutations, and mutations can either be changes in the genomic sequence, so a change in the nucleic acid base pair, or they can be deletions. So both kinds of changes can occur. You can actually get chunks of the genome dropping out, or you can get switches. And that's just a natural byproduct of RNA replication. It turns out actually coronaviruses do not mutate as quickly as some other RNA viruses. So HIV is an RNA virus, and that mutates very rapidly. Influenza is also an RNA virus, and that also has mutations as it replicates, and that's part of why you need to get a new flu shot every year, because as the influenza virus spreads, it changes, and so the flu vaccine has to be updated to correspond to the influenza viruses that are circulating in the community. While coronaviruses do not change as rapidly as influenza or HIV viruses, they do have mutations as they replicate. Most of these mutations do not matter at all. They impart no advantage to the virus at all. However, if a mutation does impart some kind of an advantage, for example, it makes the virus more transmissible, that mutation can become fixed and spread and become the dominant example of virus circulating in the community. When that happens, we call it a variant. So a variant is just a virus with a different genomic sequence. And it could be one change or it could be many changes. So for example, in the case of the alpha variant, what used to be known as the B117, originally described in the United Kingdom, in the spike glycoprotein, so the part of the virus that binds to that the ACE2 receptor, there are actually 10 substitutions and 3 deletions. Overall, in the entire viral genome, there are about 27 mutations that define the alpha variant. But we tend to focus on the mutations or changes that occur in the spike glycoprotein because we believe that's the part of the virus that's most important in terms of transmission, because that's where the virus is actually binding to the human cell. So just to give you an example of a variant and sort of how they can spread. So what a lot of people don't recognize is actually the virus that spread throughout Europe and the United States in much of spring and early summer of 2020 was actually a variant. So the vaccines are actually based on a viral sequence from the original Wuhan virus that was discovered in December of 2019 and then sequenced early in January of 2020. But by March of 2020, a variant had emerged called D614G, and just essentially that's describing the location and the change that occurred. So at position 614 of the spike glycoprotein genome, there was a substitution such that instead of having a glycine show up in the enzyme, you had an aspartic acid. And the result of that was you got a virus that was able to replicate much higher in human airway tissue, about 2 to 8 times higher, so that between March and June of 2020, this virus rapidly spread and accounted for about 3/4 of all the COVID cases in the United States and Europe. And so that's how a variant arises. You get a change in the genome that confers an advantage to that particular strain. It becomes fixed, it spreads, and we recognize it as a variant. So the World Health Organization and the US Centers for Disease Control and Prevention track 3 different kinds of variants. So the first are what we call variants of interest. And these are viral strains where they have mutations that we recognize could be associated either with increased transmissibility, increased disease severity, increased treatment failure, or potential to interfere with our diagnostic tests. So it doesn't mean that these strains necessarily will do that, but they have mutations that we recognize could be problematic. And there are 3 variants of interest currently being tracked in the United States: Eta, Iota, and Kappa. So you can see we're kind of working our way through the Greek alphabet. The World Health Organization, in addition, tracks 2 additional variants of interest, Lambda and Mu. We don't track them in the United States because they account for less than 0.1% of all the COVID cases in the US, so the CDC does not track Lambda or Mu at this time. If they were to spread more, that could potentially change. Variants of concern are SARS-CoV-2 viruses where there has been some change, either increased transmissibility, more severe disease, or reduced effectiveness of our treatments or vaccines, or diagnostic failures. There are 4 variants of concern that we're tracking right now in the United States: Alpha, Beta, Delta, and Gamma, and I'll talk a little bit more about those in 1 second. And then the last group is variants of high consequence. And basically, these are SARS-CoV-2 viruses that our vaccines really don't work against. And fortunately, at this point in time, there have been no variants of high consequence identified anywhere in the world. But as this virus continues to replicate and be transmitted around the world, there's always the possibility that a variant of high consequence could emerge. And that's why interrupting transmission is so critical, not only for preventing disease in individuals, but also preventing the chance for new variants to arise and to spread. So what about these variants of concern? So alpha, as I mentioned, was first described in the United Kingdom, and there are studies to show that it's probably about 50% more transmissible than the SARS-CoV-2 viruses that existed before alpha came along. So alpha very quickly became the dominant virus in the United Kingdom, and from there disseminated around the world, got into the United States, so that by the summer of 2020, alpha accounted for about 2/3 of all the cases in the United States. So this was a variant, clearly had increased transmissibility and was able to crowd out other strains of SARS-CoV-2 because of that. There's some data to suggest that it may be more virulent, meaning that it may cause more serious disease. That's a little unclear, and probably no real change in vaccine effectiveness. So fortunately, our vaccines work very well in protecting us against the alpha variant. The beta variant, which used to be called B1351, was first described in South Africa. This variant also is more transmissible, but for whatever reason, has not really disseminated globally to the extent that alpha or delta has, which is actually good, because in addition to the mutations that make it more transmissible, it does have some additional mutations that make it less responsive to monoclonal or vaccine antibodies when you measure it in the laboratory. So if you take this strain of virus and use antibodies that you isolate either from people who've been infected with SARS-CoV-2, or use monoclonal antibodies made in the laboratory, or who have been vaccinated, the levels of neutralization, the ability to neutralize this virus, are lower relative to what they are to alpha and some of the other strains. Beta, as I said, really has never been an issue in the United States and accounts for less than 0.1% of all our COVID cases. Gamma is very similar to beta, first described in Brazil, also called P1. Very similar in terms of how it behaves in the laboratory, of having decreased response to vaccine or monoclonal antibody levels. Clinically, how important that is remains unclear. And fortunately, while gamma has spread a little bit around the world, again, never really been an issue in the United States. So let's turn to delta. So delta, originally described in India, also known as B16172, currently now accounts for about 99% of all the COVID cases in the United States. And as I mentioned, as RNA viruses replicate and spread, they can change. And there are actually now about 9 different subtypes of the Delta variant, and we call them A1, A2, so forth. And if you lump them all together, as I said, it's about 99% of all the COVID cases in the US right now. So essentially, all we have is Delta variant at this point in the United States. So the Delta variant is approximately 2 times more transmissible than the original SARS-CoV-2 variants. And that's probably part of why it's become so dominant. And it's been able to crowd out all the other variants. So alpha, as I mentioned, had been responsible for about 2/3 of all the cases in the US. When Delta came along, it was very quickly able to outcompete alpha and become the dominant variant, and essentially outcompeted everything else as well. There are some data to suggest that it may be more virulent or pathogenic as well. So this is some data from a retrospective cohort study in Ontario, where they looked at hospitalizations, and they compared hospitalizations from Delta compared with Alpha and non-variants of concern. And it looked like the Delta variant was associated with a 49% increased risk of hospitalization and a 51% increased risk of death compared to alpha, and alpha was actually higher than the non-variants of concern. So some preliminary data to suggest, in addition to being more transmissible, it may be a more deadly virus. There's some additional data from Scotland as well. So these are data from April through June of this year, looking at almost 20,000 SARS-CoV-2 infections, about 377 hospitalizations, and about 1/3, a little more than a third, turned out to be due to Delta virus. So this was as Delta was moving into the United Kingdom. And what they found was that the Delta virus had an 85% chance, higher rate of hospitalization compared with the Alpha and other variants that had been circulating at that time. They also tried to look a little bit at vaccine effectiveness, and it looked like the Pfizer vaccine was about 80% effective in preventing hospitalization against the Delta variant. And the AstraZeneca vaccine, which is an adenovirus-based vaccine that's not available in the United States, but one of the two vaccines they've been using in the United Kingdom, was about 60% effective in preventing hospitalization. There was another study also done in the UK where they also looked at adults with symptomatic COVID-19 caused either by Alpha or Delta variant. And as you can see from these numbers, the mRNA vaccine, the Pfizer vaccine, had pretty good effectiveness against both variants, so about 94% against Alpha, 88% against Delta, so a little bit lower, but still very good. And the AstraZeneca, again, fine effectiveness, so not quite as high as the mRNA vaccine. So AstraZeneca, just to remind you, is an adenovirus vaccine. And about 75% effective against Alpha and about 67% against Delta. So Delta, little worrisome in that the vaccines may not be quite as effective against Delta as they have been against some of the other variants, particularly Alpha, which was kind of the dominant variant in the UK and the United States and a number of other countries before Delta came along. So what about breakthrough infections? So breakthrough infections are infections that occur in previously vaccinated individuals. So this is a study of 227 healthcare workers at the University of California, San Diego healthcare system, so just down the coast from us. And that what they found was that the difference in terms of symptomatic disease was really no different. So 84% of fully vaccinated healthcare workers who became infected, had a breakthrough infection, were symptomatic, compared with 89% of unvaccinated healthcare workers. Overall, the vaccine efficacy was very good, 94 to 96%. But if they limited it just to breakthrough infections that occurred in July, when the Delta accounted for essentially all of those infections, vaccine effectiveness was only 65.5%. So it seemed to fall off when you just focused on Delta. Most of these were mild to moderate infections, so vaccines still good against serious disease. What about transmission? So this is a study also from the United Kingdom where they looked at household contacts of patients with COVID-19. And so what you're looking at, and I don't know if you can see my mouse. I actually don't see my mouse, but what you're looking at are, so the top line is number of household contacts, secondary cases. So about 10% of the household contacts got infected with SARS-CoV-2 from the index cases. And both the AstraZeneca adenovirus vaccine and the Pfizer mRNA vaccine were pretty equally effective, about 50% reduced risk of infection if you had been vaccinated. So some data to suggest that yes, these vaccines actually are effective in reducing transmission in addition to reducing disease. This is another study also from the United Kingdom looking at household contacts of healthcare workers. And again, very similar, about a 54% reduction in fully vaccinated individuals. So fully vaccinated for a 2-dose vaccine is usually 14 days after the second dose. And there was actually some protection, a 30% reduced risk after 1 dose, but the full effect required getting both doses of the vaccine. And unlike the Johnson & Johnson adenovirus vaccine, the AstraZeneca adenovirus vaccine is a 2-dose vaccine, just like Pfizer and Moderna are. These are some more data from the United States. So this is a study looking at about 212,000 New York State residents and looking at cases of COVID-19. And what they found was that vaccine effectiveness against any new infection dropped from about 92% to about 80% over the roughly 4-month period that this study was done, when Delta was really kind of taking off. So by July, Delta is the predominant strain circulating in New York. But that vaccine effectiveness against hospitalization remained excellent. So 92 to 95% against serious disease. So even though there were more breakthrough infections over time, the vaccines were still doing, and these were the 2 mRNA vaccines primarily. Very few people had gotten Johnson & Johnson in this study. So this is mainly the Pfizer and Moderna vaccines. And they remained very good against hospitalization and serious disease. So this is a study, let's see if I can close, but I can't find my mouse. If I could close my control panel, then I could actually see all of my slides, but I can't find my mouse to figure out how to do that. So anyway, another study of vaccine effectiveness. This is from actually Los Angeles County. This was published in the end of August in the MMWR. And basically, if you limited it to just July, when Delta accounted for 91% of all the infections we were seeing in LA County, unvaccinated people were 5 times more likely to be infected than vaccinated individuals, and 29 times more likely to be hospitalized if infected. And so vaccines not only preventing infection, but doing an excellent job at preventing serious disease, even with the Delta variant. One of the unfortunate outcomes of both our policies and practices is that we're seeing more young people get sick with COVID-19 because the vaccination rates are lower in younger individuals than older individuals. And so if you look at who ended up getting hospitalized, unvaccinated COVID-19 patients were more likely to be younger than vaccinated COVID-19 patients, previously vaccinated COVID-19 patients who ended up getting infected and hospitalized, and less likely to have comorbid conditions. So while it is uncommon, COVID-19 disease can be very serious in younger individuals, even in the absence of comorbid disease. In terms of how we're doing with our older adults, so our vaccination rates are actually pretty good in our older adults. In the country as a whole, about 83% of individuals 65 and older are fully vaccinated. I don't know the numbers off the top of my head for California, but I would assume that they're fairly similar. So this was a study that came out in mid-August. And again, vaccine effectiveness really excellent across the board, both in individuals 65 to 74 and over the age of 75. And you can see the numbers are from the mid 80s all the way up to the mid 90s, with the mRNA vaccines tending to be a little more effective than the adenovirus vaccine, but you can't, this wasn't a trial, you can't directly compare them like that. So if you really want to know what the difference in the effectiveness was between the different vaccines, what you would want to do is an actual trial to compare them. So this is another study actually just published a couple of weeks ago, again, adults over the age of 50 between January and June of this year. So Delta's kind of taking off at the end of this study, but a lot of these patients are going to have had Alpha or other strains rather than Delta. These were people who were hospitalized with COVID-like symptoms or presented to an emergency room or urgent care clinic with COVID-like symptoms. So roughly about 10% of them ended up having confirmed COVID infection. So you can see out of the roughly 41,500 hospitalizations, there were 4,321 confirmed SARS-CoV-2 infections, and out of the 21,500 urgent care ER visits, 3,251 ended up having confirmed COVID. So not everybody had COVID in this study. And when you looked at the ability of the vaccines to prevent serious disease, again, you're seeing very good results. So the Pfizer, two-dose Pfizer was 87% effective against hospitalization, 89% against urgent care visits. Moderna was a little higher in the low 90s. And the Johnson & Johnson, which is a one-dose vaccine, 68% for hospitalization, 73% for ER urgent care visits. So all of the vaccines above the 60% target that the FDA originally set when they put out the call for vaccines. And in fact, vaccine efficacy has been maintained over a 6-month period, which is about the total length of data that we have available to us. So this study was actually just published last week in the New England Journal of Medicine. And this was part of the data that the FDA was reviewing as it was trying to decide whether or not to recommend booster shots. These are also part of the data that the Advisory Committee for Immunization Practices is reviewing actually today and tomorrow when they're deciding whether or not to recommend booster shots, and if so, in whom. And what you can see is that vaccine effectiveness against severe disease, this was from the original Pfizer trial, so this is only the Pfizer vaccine, remained 97% even after 6 months, 91% overall against any SARS-CoV-2 infection. However, when they did limit it to people who had at least 4 months after the second dose of vaccine, they did see a little bit of drop off in terms of the vaccine effectiveness, down to about 84%. So some data to suggest that vaccine immunity does wane over time, even though the effectiveness against serious disease seems to remain excellent, at least through 6 months for which we have data. So now the question becomes, should we be giving boosters, and if so, to whom? Well, the first question you want to know the answer to is, well, do boosters boost? I mean, do they actually work? And so these are data from the laboratory. So what you're looking at is you're looking at 2 different types of neutralization tests. So what's going on here is you take virus in the laboratory and you take antibody either from sera from patients who've been vaccinated or sera from patients who've been infected with SARS-CoV-2, and then you run them through different kinds of assays and see, can you neutralize the virus? And so you can see here we're looking at 23 participants, not big numbers, and the only difference between the top set of bar graphs in the bottom is there different kinds of neutralization tests. So at the top bar graph, where you're looking at the light green and the oranges, essentially what you're seeing is the level of neutralization a certain number of days after different doses. So for example, nobody has any neutralizing antibodies before the first dose, then what's the neutralizing antibody level 7 days after dose 2, 1 month after dose 2, and before you give dose 3. And the difference between the green and the orange is the green is what they're calling wild type, or the Washington, what used to be known as the Washington strain, and the orange is neutralization of the Delta variant. And if you go all the way to the right of the slide and look at the two tall bar graphs, those are 7 days and 1 month after the third dose. And you can see that if you go 1, 2, 3 columns to the left, what the levels are right before the third dose, and you get a very good response to a third dose. So your neutralizing titers go up somewhere between 5 to 7 times what they were before you give this dose, and even higher than what you got 1 month after the second dose. So evidence to suggest that booster shots actually do booster. Bottom, same thing. The green is again wild type, the blue is the Delta variant, but again, just showing that in fact, after dose 3, so the second from the right is 1 month after dose 2, all the way to the right is 1 month after dose 3, and again, you get a nice boost response. So data to show that for the mRNA vaccines, doing a booster does actually boost. This is the exact same thing, but this is looking at the AstraZeneca vaccine, which, remember, even though it's an adenovirus vaccine, is a 2-dose vaccine. If you look at the bottom half of the graph, you're looking at the first block of squiggly lines is alpha variant, the second is beta, and the third is Delta. And remember, the beta is the one where the vaccines seem to be a little less effective. And going from the blue dots to the green dots is just 28 days after second dose to 28 days after the third dose. And you can see the general trend in the lines is going up. So you are getting an enhanced response after getting a booster. And the top line is just showing the average level of the neutralizing titers. And again, you can see things go up as you give more doses. The other thing that they did in this particular study is they varied the timing of the second and third dose. And what they found was that if you gave your booster 44 to 45 weeks after the second dose, as opposed to 8 to 12 weeks, you actually got a much better response. So delaying the booster actually enhanced the immune response that you got. And there are some data to suggest that may be true for the mRNA vaccines as well. In terms of effectiveness, the only data that I'm aware of are data that, again, were just published last week and actually came out right before the FDA had their meeting. And this is a study of almost 1.2 million Israeli residents over the age of 60. So as you may know, Israel has been using the Pfizer mRNA vaccine almost exclusively. They've had a very aggressive campaign to vaccinate their entire country in people over the age of 12. And what they found over the course of the late spring and summer of 2021 was their case rates were rising again. So they decided on July 30th of this year to start instituting booster shots in individuals 60 years and older. So in contrast to the United States, where a supplemental third vaccine has only to this point been recommended in individuals with immunocompromised diseases, in Israel, they decided to boost anyone over the age of 59. And so what they did was they compared over the course of the first 2 weeks of this program infections in people who had gotten a booster with people who had not gotten a booster. And what they found was boostering both reduced the likelihood that you would become infected by a ratio of 11. Is a little interesting how they did the statistics. So it's not quite factor of 11, but it's a ratio of 11, and it lowered severe disease by almost a ratio of 20. The absolute difference in terms of severe illness was 7.5 cases per 100,000 person day. So if you gave boosters to 100,000 people, you would prevent 7.5 cases of severe disease over what would have happened if you had not given those boosters, based on these data in individuals 60 years old and older. What about adverse reactions to the vaccine? So this is also a study out of Israel, looking at 884,000 individuals of all ages, all adults. And one of the concerns that came out of this study was a risk of myocarditis. Again, this is only the Pfizer mRNA vaccine, so this is not the adenovirus vaccines at all. They don't use them in Israel. And these were occurring roughly at a rate of about 3 per 100,000 persons. So about 3 cases of myocarditis for every 100,000 vaccinations. Interestingly, more likely to occur in young men. Exactly why that is, I don't know. I have not heard a good explanation for. Importantly, though, what they also did was they looked at the risk of the similar outcomes from infection itself, right? So people are like, oh no, I might get myocarditis from getting the vaccine. Well, your risk of myocarditis is actually 3 times higher if you get SARS-CoV-2 infection than getting the vaccine. So even though there is a very small risk of myocarditis, it's substantially lower than if you were to become infected with SARS-CoV-2. Interestingly, there was an increased risk of appendicitis and herpes zoster infection. And I don't know if that's spurious or quite what's going on there, but it'll be interesting to see if other studies also show that. So these could be chance events. So chance events can occur, but it is interesting that appendicitis and herpes zoster infection did occur more commonly in vaccinated individuals, and exactly why I don't have a good explanation for you. So what I'd like to turn in the remaining time, and then really delighted to answer any questions, is talk a little bit about COVID in pregnancy. So up from January 20th of 2020 up until 2 days ago, there have been almost 124,000 cases in pregnant women reported to the CDC in the United States, and 159 deaths. Roughly about 18% hospitalization rate, almost 22,000 hospitalizations. And the top graph that you're looking at is just the age distribution of who got infected. So basically between the ages of 15 and 44, and I suspect if you were to look at an age distribution of pregnant women, it would probably look fairly similar to that. Among hospitalized cases, 3.4% ended up in the intensive care unit. That's about what you would expect overall, maybe around 5% if you took all comers. But in general, remember, pregnant women tend to be much younger, substantially younger, and probably healthier than the average person who gets admitted to the hospital with SARS-CoV-2. At the bottom graph, you're looking at the number of cases based on ethnicity or race, and you can see that roughly there have been a similar number. It's just an absolute number of cases. It's not percentages at all, but you can see there have been a similar number of cases of pregnant Hispanic or Latinx women as there have been in white non-Hispanic women. But given that the white population is larger, if they were to do a rate, the rate would be higher in Hispanics. And then it's Asians tend to have the lowest rates. They also have the highest rates of vaccination. And then Black non-Hispanic, and at the last column is multiple race or other race non-Hispanic. So what about outcomes in pregnant women who get COVID-19? So this is a study of almost 462,000 women between the ages of 15 and 44 with confirmed SARS-CoV-2, 89% of whom were symptomatic. 6% of the symptomatic women also happened to be pregnant. So it worked out to be 23,434 pregnant women with symptomatic COVID infection. So pregnant women were 3 times more likely to be admitted to an ICU with SARS-CoV-2 infection than non-pregnant women after controlling for age and race. And they were about 3 times more likely to end up on a mechanical ventilator if they were admitted. They also had higher rates of extracorporeal membrane oxygenation, what's known as ECMO. It's essentially cardiac bypass in the intensive care unit. And they did have a 70% increased risk of death. Now, the overall numbers were still very small. So the rates of ICU admission are about 11 ICU admissions per 1,000 cases. So that's still a pretty low number, and 1.5 deaths per 1,000 cases, but higher in pregnant women than similar non-pregnant women. In terms of birth outcomes, this is another study, also data compiled by the CDC, looking at almost 4,000 live births between March and October of last year. And what they're seeing is a slight increase in preterm deliveries relative to what you would expect otherwise. So almost 13% were preterm, and on average, they would have expected about 10% to have been preterm. Very little perinatal transmission, so that's good. Only 2.5%, 2.6% perinatal transmission. So in general, so far, has not been a lot of transmission. Most of these infections occurred in the 3rd trimester. So we're still accumulating data on pregnant women who become infected in the 1st trimester. What about vaccines? So we have several vaccine reporting systems, but 2 well-known ones. One is run by the FDA, the Food and Drug Administration, called the Vaccine Adverse Events Reporting System, or VAERS. And the second one, VSafe, is actually a registry run by the CDC. And as part of that registry, they have a pregnancy registry as well. And that's for women between the ages of 16 and 54 who've received either the Pfizer or the Moderna vaccine. And in terms of just local reactions to the vaccine, so fever, chills, sore arm, lymphadenopathy, no real difference between pregnant and non-pregnant women. So pregnant women were more likely to report nausea or vomiting after the 2nd dose than non-pregnant women. In terms of outcome, there were 712 live births that they looked at. 12%, almost 13% spontaneous abortions, 0.1% stillbirths, and 1.2% induced abortion and ectopic pregnancy. And these percentages were felt to be very similar to what you would expect prior to the pandemic. So at least some preliminary data to suggest that the vaccines are safe in pregnant women, and they do not cause any problems for the fetus or the subsequent neonate. So how are we doing in terms of vaccinating pregnant women? So through 9/11 of this year, about 30% of pregnant women have been vaccinated. The highest rates are in Asian women, almost 45%. The lowest rates are in Black African Americans, about 15%. Whites and Hispanics are somewhere in between, running about 30 to 33%. So the top set of bars is just the percentage of pregnant women vaccinated. The bottom is broken out by race and ethnicity, where the pink line at the top is Asians, the orange line at the bottom is Black African American, and then Hispanic, Latino, Latinx, white, and other are the colors in between. So not doing as well in pregnant women as we are in the adult population as a whole. And one of the things we can talk about is how do we try to improve those numbers. So just to bring it all together, I apologize, that was a lot of ground to cover in a relatively short period of time. But so right now, Delta variant really is the only variant in the United States. So everything that's happening right now is Delta. Good data to suggest that it is more transmissible. It's about twice as transmissible, possibly more virulent as well. So data from Canada and the UK, as I mentioned, to suggest that it may be more virulent as well. I think there are good data to show, at least in the laboratory, that boosters actually do boost. So you can boost an immune response by giving a booster dose. And there are some preliminary data from Israel, which we talked about, to suggest, at least in individuals 60 and older, that giving a booster can potentially reduce infections and serious disease. However, our current vaccines do remain highly effective against serious disease. So even though breakthrough infections have been increasing, our vaccines do still work very well against preventing hospitalization, ICU admission, and deaths. And then there's finally, pregnant women are at increased risk for serious death and serious disease and death. While the numbers are still low, 10 per thousand cases for serious disease, roughly 1 per thousand cases for deaths, that is much higher than what occurs in similarly aged and health-wise non-pregnant women. And the data so far suggests that vaccines are safe in pregnancy, both for the women and for the fetus. And so anything you can do to encourage pregnant women to get vaccinated would just really be terrific. I was actually covering the COVID service at Ronald Reagan Medical Center this past weekend and had to deal with unvaccinated pregnant women with COVID, as I had to in July. And it's just a tragedy to see young, otherwise healthy people battling for their lives with what should be vaccine preventable diseases. So I think that's it. I'd be delighted to answer any questions you have, and thank you very much for allowing me to spend some time with you this afternoon.
Great. Thank you so much, Dr. Brewer. That was a lot of information that you gave us. So I really appreciate all of the very thoughtful information you provided and all the data that you gave to support your topic. So thank you so much. I'm going to remind everybody to please put some questions in the chat if you have any. And we're lucky enough that Dr. Brewer's still with us for we have a whole half hour left that we can kind of pick his brain, and he's the expert in this. So anything you have to ask him now would be a great time for it. So please go ahead and put those in the chat. I'll start with a few that came up while you were presenting your information. And I think with this was kind of covered because you originally began with data on the AstraZeneca vaccine, and then a few people were asking about the effectiveness of the Moderna vaccine. So I think it was covered because you went through that eventually, but could you just reiterate like the different effectiveness, like as simply as possible, of the different vaccines for us again?
Sure. So in general, the mRNA vaccines, of which there are two, Pfizer and Moderna, are pretty comparable. So they tend to have effectiveness against serious disease, hospitalization, and death in the low 90s. There are some data that were just published within the last week that suggests after about 6 months, the vaccine effectiveness of Pfizer falls off a little faster than the Moderna vaccine. So the Moderna vaccine was staying in the low 90% in terms of effectiveness after 6 months, and the Pfizer dropped down to 77%. So potentially a difference there, but a little hard to know for sure because it's not a direct trial, and they may not be completely comparable populations because the Pfizer vaccine was actually out first. And so, for example, frontline healthcare workers like myself were much more likely to get vaccinated with Pfizer than with Moderna because it was available first. And we're also more likely to have higher exposures than the general population, in part because we work with potentially infectious COVID-19 patients. So not sure they're entirely comparable, but both very well. In terms of Johnson & Johnson, the effectiveness of that tends to be a little lower, so it tends to run in the roughly mid 80s for serious disease, 85, 86% against serious disease hospitalization, and a little lower into the 70s for infection. The company actually just released some data this week on boosters, and it looks like, again, the boosters work very well in Johnson & Johnson. In terms of side effects, Johnson & Johnson, the adenovirus-based vaccine available in the US, has been associated with blood clots and Guillain-Barré. The blood clots are more likely to occur in young women, and they occur in the order of about 2 to 11 per million doses, so very, very low. In terms of the mRNA vaccines, at least for Pfizer, increased risk of myocarditis may be true of Moderna as well, but not as well studied, and that seems to occur in young men. So the big difference in terms of the side effects is the risk of myocarditis with the mRNA vaccines and the risk of blood clots and Guillain-Barré with the adenovirus vaccine.
Great, thank you. I think that's a great explanation, laying it all out for us. Can you also speak to, let's say you have we're working with a client, the home visitors are working with a client who is hesitant to get the vaccine and potentially open to getting the Johnson & Johnson vaccine since it's 1 dose versus the Pfizer and the Moderna since they're 2 doses. What would you say to that client, or kind of what kind of advice do you give, given that the Johnson & Johnson potentially slightly less effective, but
Yeah, I would give whatever vaccine they would take. So I would have no hesitancy giving someone a Johnson & Johnson vaccine if I only thought I could get a 1-dose vaccine into them, because I think where the data are really clear is any vaccination is better than no vaccination. So while everything being equal, I would probably tend to use an mRNA vaccine over an adenovirus-based vaccine if I had a patient who I thought would only be willing to take one dose. I would definitely have used the Johnson & Johnson, have no hesitancy with doing that. The other place I might do Johnson & Johnson is young, healthy males. So for whatever reason, there does seem to be an increased risk of myocarditis. So in an otherwise young, healthy male, Johnson & Johnson might be a good choice for them as well.
Great, thank you so much. That's a good answer. I think that will be very helpful for our home visitors. Another question in the chat is asking about some of the information or potentially that's circulating about the vaccines and fertility. So some people have heard that the vaccines affect a woman's fertility. Can you provide any information about where that comes from and what you might say to someone?
Yeah, I have no idea where that comes from. There's also, I guess there was some rap singer or some woman singer who apparently was going around saying that it caused testicular inflammation too, and I don't know where people come up with this kind of stuff. I have not seen any data to suggest that. So the study I showed you from Israel, that was almost 890,000 people that they've followed for who've been vaccinated. Now that was all Pfizer. That's the only one they used, but the original trials, the Pfizer trial was about 45,000 people. The Moderna trial was about 30,000 people. Johnson & Johnson, I think, was about 35,000. They've followed these people now for over 8 months. We have vaccinated almost 180 million people in the United States. And I've not heard any signals about problems with fertility either in men or women. So I would think if after giving it to 180 million people, if it were really a problem, we probably would have seen that.
Great, thank you. I appreciate that. Another question for you. If someone were to be vaccinated and then get a breakthrough infection, what would be the clinical advice for quarantining? Is it similar to the previous advice? Is it different? Would you?
Yeah. So doesn't change at all if you actually become infected, right? So if you have a breakthrough infection, you still have to isolate. So just to remember, isolate is what you do if you're infected. Quarantine is what you do if you're exposed, but you don't know whether or not you're infected. So if you're vaccinated and you get exposed, then what the CDC and the LA County Public Health Department recommends is that you go into quarantine and you do a test to see if you're positive within 3 to 5 days. And if after 3 to 5 days and you test negative, you can come out of quarantine. If you become infected, so your test is positive, then you have to remain in isolation for a minimum of 10 days if you're asymptomatic, or if you're symptomatic, a minimum of 10 days, or until your symptoms are improved and you're afebrile off any antipyretic medicine, so acetaminophen, ibuprofen, nonsteroidals, things like that. So the recommendations don't change if you're infected, they only change if you're exposed. So if you're exposed and unvaccinated, you have to stay in quarantine for the full 10 to 14 days. If you're exposed and vaccinated, you can come out of quarantine after 5 days if you have a negative test.
Great, thank you. That's very helpful. Can I ask you if you have any data that you can share on the COVID vaccine and breastfeeding or lactation?
Yeah, so I haven't looked into that, but these are non-replicating vaccine, so it shouldn't be an issue at all. I think the real question is, what's the antibody transfer level to the infant? And that I have not looked at data, so I don't know. But in terms of the vaccine itself, neither the mRNA or the adenovirus vaccines are replicating vaccines. So unlike measles, mumps, rubella, which is an attenuated live viral vaccine where the virus actually replicates, there's no replication here. So it shouldn't be a risk from the vaccine itself. And the question is just, how well do the antibodies cross in breast milk? And that I don't know.
Great, thank you. I appreciate that. We got another one here in the chat that I'll read off for you. Is there any research on getting a booster vaccine that's different from the original vaccine? So if you got Pfizer first and then you got the Johnson & Johnson vaccine,
Yeah. Yep. So there are data. Actually, the best data are between Pfizer and AstraZeneca, because they've actually studied this in the United Kingdom, and mixing the vaccines actually gives you a better response. Mixing 2 doses gives you a better response than using 2 doses of AstraZeneca or 2 doses of Pfizer. Interestingly, the order matters. So if you get an AstraZeneca first, so the adenovirus first, and then boost with the mRNA vaccine, you get a better immune response than if you give the mRNA first and then boost with the adenovirus vaccine. There are very limited data. So Johnson & Johnson reported 3 people, so not a whole lot, who accidentally got Moderna after Johnson & Johnson, and they had good immune responses as well. But we don't really have data on mixing the 2 mRNA vaccines. So what happens if you mix and match Pfizer with Moderna? So that's not recommended at the moment. So if the Advisory Committee on Immunization Practices does recommend booster shots, I'm sure they'll recommend that you get boosted with whatever you got originally. But there are some data to suggest that mixing vaccines, particularly if you go adenovirus first and then mRNA vaccine, will give you a very robust immune response.
Great, thank you. That's really interesting. I had not heard that, so that's great information. Can you talk about the COVID vaccine and the flu shot that's coming out now? And
Sure. So yeah, so definitely get both. If you haven't gotten your COVID vaccine, please run out and get it, or encourage your clients or patients to get it. You can do them at the same time. I would recommend you do them in different arms. So don't put them both in the left arm, for example. They will tend to have similar side effects. So fevers, myalgias, swollen glands, just a little bit of fatigue and malaise, usually better within 24 to 48 hours. The COVID-19 vaccines are probably more likely to give you a sore arm than the influenza, and the influenza may be a little more likely to just make you feel yucky for a day or two, but no problem to do them together. I just wouldn't do them in the same arm.
Great, thank you. And the advice is to definitely get both.
Definitely get both, and I think it's reasonable to space them out. So get your COVID now, right? Everybody should be COVID vaccinated by now. So anyone who's willing should be just vaccinated right away. In terms of when to get your influenza vaccine, so you can get them now. They are available. I would suggest waiting at least till October. There's some data to suggest that the influenza vaccines also wane over time after about 4 to 6 months, and we tend to peak our influenza cases in January and February. So getting vaccinated in October is probably better than September. But if you're going to see someone in September and you're not going to see them again until January, then I would definitely go ahead and give them influenza vaccine at the September visit. But if you're going to see them in October, I'd probably wait till October and vaccinate them then.
Excellent. Thank you so much. Another question for you. What about, or what kind of data can you share about the vaccines in younger children, like the 12 to 18-year-old range?
Yeah, so Pfizer apparently is providing data to the FDA, or has provided data to the FDA on 12 to 15-year-olds. So remember, the Pfizer is actually approved already for, for 5 to 12-year-olds. I'm sorry. And what it shows is that the immune responses are as good as in adolescents. They actually use a smaller dose vaccine. So the typical Pfizer dose is 30 micrograms. The dose for 5 to 12-year-olds is a 10 microgram dose, but they're still getting good antibody response levels. The hope is that those data will be reviewed and the vaccine will at least get an emergency use authorization sometime within the next several months. The hope is sometime by Thanksgiving or Christmas at the latest, we'll be able to go ahead with 5 to 12-year-olds. There are studies ongoing right now down to 6-month-olds, which is the cutoff for influenza vaccine too. So influenza vaccines are 6 months and above. For whatever reason, the companies decided to do them in chunks, and I don't know why that is, why they just didn't do studies 6 months and above, but they did it in age blocks, and they basically worked the blocks down. So we'll have to wait longer to get data on under 5-year-olds. And Moderna seems to be about a month or two behind Pfizer in terms of organizing their trials and collecting data.
Great, thank you. Here's an interesting question that came in the chat. Do you have any information on how to encourage somebody with a needle phobia to get the vaccine, or maybe if there's like a missed option eventually coming down the line, like there is for the flu?
Right, yeah. So I'm not aware of anybody working. So I had this exact same question on Air Talk today, and I'm not aware of anybody working on a non-injectable COVID-19 vaccine, but I haven't specifically looked to see if someone might be working on one. I suspect it would be very doable for the adenovirus-based vaccines. Probably hard to do for the mRNA-based vaccines, just because the whole challenge with the mRNA vaccines is stabilizing them enough so they can get taken up by cells, and it's easier to take things up that are directly injected into cells than having to work their way to be absorbed and presented to cells. So potentially we'll see one for adenovirus. I could be wrong, but I don't anticipate that we'll see a non-injectable for the mRNA vaccines anytime in the near future. I would just tell them, it's a small needle, it's quick. Look the other way, think happy thoughts, and I used to have needle phobias too. So you just, whatever, all the tricks you all are probably much better at this than me, but all the tricks you use to convince people to let you jab them with a needle.
Great, thank you. And I'll look for the link if I can find it before the webinar is over. We have a link to our resources on our blog, and there are some videos in there with real people talking about their personal experience getting the vaccine, and that may be one. I haven't watched them all, so I don't know for sure, but there may be something in there about kind of what that felt like and how the needle, how big it was, et cetera. So I think it may be helpful just for someone else to see somebody talk about that directly and say this, it's not that bad or whatever might be helpful. So I'll look for that link and put it in the chat. Another question for you, and I think we'll see if there's any more final questions for Dr. Brewer. Keep putting those in the chat, but I have one kind of final piece for you. In your experience working with clients and patients, what has been the most effective thing that you've said that's convinced people to get the vaccine? If you can think of that on the spot.
Sure. What probably works best is getting a trusted advocate on your side. So rather than listening to an expert, people are much more likely to listen to their primary care physician or healthcare worker with whom they have a relationship, or a pastor, or a family member. So trying to find an advocate that they respect and listen to, who would be willing to help you convince them to get vaccinated. I think that tends to work better than just giving them information. I think for most people, it's probably not a lack of information, though there clearly is a lot of misinformation out there. So for the people where it is just misinformation, correcting that, but for people where it's not, trying to identify a trusted advocate who could help you discuss getting vaccinated.
Excellent. Thank you so much. I think that's a really great answer, and also really highlights the role of our home visiting network and how they can be that trusted advocate for, particularly for the home visitors who have worked for a long time with the families that they serve. They are that person for those families. So the good news, I think, in listening to that is that you as home visitors are the best person to talk to somebody else about this, because the families trust you, so you can be that advocate for them. And I think that sounds like that could be a really, really useful. So great. Any final questions for Dr. Brewer before we let him go? I'll wait just a second to see if any more come into the chat. And while I'm waiting, I'll just highlight that I did put that link in the chat. It doesn't look like you can click it, but hopefully you guys can copy and paste it, as well as, or I can also send it out to everybody via email too. So I'll make sure to do that. But that will take you to a bunch of resources that we have compiled about COVID-19, the vaccines, and how to talk to people about the vaccines, et cetera. So I'll make sure everybody gets that. And we will be putting Dr. Brewer's recorded webinar up on that link as well, so that everybody can watch it again if they want to. I don't see any more questions coming in, so I think you answered everything and more that we had for you. So I really, really appreciate the time that you took to put this together for us and answer all of our questions. I think this is great information that everybody will be really well served in knowing. So thank you for your time, Dr. Brewer, and thank you everybody for being here with us today and for all of your attention. I'll follow up in the next week or so with a link to the recording. And if you have any questions in the meantime, you can always reach out to me, and you can, and I can set you up with Dr. Brewer. We can try to answer your questions with any resources that we have. So thank you again, Dr. Brewer. This was such a delight to have you here. Really appreciate it.
Yeah, no, my pleasure. Thank you for having me. Have a great afternoon.
Yeah, thank you so much. Bye, everybody.